that Leon Au gave me for a talk a couple of years ago, and I thought it kind of fitted, but you know, some of it may be anything but the truth. But it's nice with webinars because you've got a little bit of, can you hear me? Yeah.
Yes, we can. Please, everyone, sorry, just please, everyone keep their mics off, please. Thank you.
You get a little bit of time in webinars to go into things in a little more detail than otherwise do. You know, I'm so used to standing up at meetings and being asked to tell you everything about tubes in 10 minutes, which of course is pretty much close to impossibility. But then for many people, they're not doing tubes. It's not such a big deal anyway, and they only need to know a snapshot. But this talk is more detailed and more for people who might be thinking, who do a lot of glaucoma surgery, might be thinking about them, might do them, might just wonder what they're useful for. Some of the English in this talk's a little bit funny, like the untrappable. And I think you know what I mean, though, when I talk about patients where you've got so many trabeculectomies or extensive blebs that you really don't know what to do next. And this is more a case that was common in the 1990s than it is now. When mitomycin first started getting sloshed around liberally, we ended up with a lot of very widespread blebs. So this patient on the right has already had 3 trabeculectomies, and there's really no space to do anything else. And the point about these really is that tubes are versatile, and in these patients where you might be tempted to do something else because you think a tube's impossible, you can actually very often get one in the cleavage between the blebs, or obviously you can use a different site completely and purely, but it's worth pointing out that it isn't absolutely necessary to lose the real estate of the supratemporal quadrant just because there's pre-existing blebs. One of the reasons I ended up doing a lot of tubes was I did a glaucoma clinic adjacent to a retinal clinic at a time when there were a lot of secondary glaucomas coming in, patients with buckles. And it was typical in those days really to do trabs in these patients. But the trabs really have a very poor success rate in these eyes with very scarred conjunctiva. And I realized early on that the logistical problems of working around buckles are actually not that difficult as long as you're prepared to do wide opening of the conjunctiva, a lot of conjunctival mobilization, and put the plate quite far back.
Hello.
I did learn early on, though, not to be too enthusiastic about removing buckles, because sometimes you find there's absolutely no sclera underneath them. But you can get around buckles, and this patient, as you can see here, with a modern low-lying 276, you can actually just put the plate on top of it if you're using a bar belt. You can't do that with an amide valve, which is rather thicker, but with a bar belt, it's quite thin, and you can actually go just on top of it and stitch the plate to the buccal capsule. So there are a lot of no-hope trab cases where you can actually do a tube adequately. This is a patient with a pemphigoid, and you see people with very scarred conjunctivas. And again, it's tempting to avoid tube surgery because you think it's going to be very, very difficult. But often the logistics can be worked around. And for instance, in patients with pemphigoid, assuming that they've had good preoperative chemotherapy for the pemphigoid, you can actually get the eye mobilized and the tube in once you open the conjunctiva. They aren't actually impossible to do, despite your initial impression. Silicone oil is another case where oil destroys trabecular mesh, where it can destroy trabeculectomies, whereas it doesn't block tubes, but it might block the tube. This one's got a supermid in it, preventing the oil going up the tube, but you can see how the oil sticks to silicone. There's not only the untrappable, but the undiodable, where even CPC might be impossible. I think Panayota might remember this patient. I think her eyes almost popped out of her head when I started the operation. See, what on earth is this guy trying to do? But as you can see, she's still doing very well, by the way, Panayota. She was, I'm pretty sure you were assisting this one. But she had, you can see down below, there's more sclera than there is up above. But you can, with various maneuvers get around this. Sometimes the sclera is very thin and you can't put the plate on, such as in patients with osteogenesis imperfecta. But even then, you can put an underlay of donor sclera or donor pericardium. This patient, you see here, the choroid was virtually bursting out when we opened up the conjunctiva. So you have to be very, very careful. But the logistical problem is getting the plate on, which you can use an underlay of pericardium, or putting the tube in. And again, you can use an underlay of pericardium. And you can put more pericardium or fascia lata or sclera or cornea on top. So even this sort of case is it's not impossible. There are patients where you might crash, the pressure might crash if you do CPC. And the eyes typically that you've got to watch out for are those with chemical burns or those who've had a lot of CPC before. This patient had chemical burns. You may say, well, you've got to try and avoid the lumbar ischemic area, but with a chemical burn patient, the biggest risk is hypotony. Ciliary body's often been damaged by the chemical burn. Need to try and avoid causing hypotony. It's not actually the external problem. And there are those where hypotony might be devastating, and venous malformation, Sturge-Weber syndrome is a situation where you really, really must not get hypotony. The very photogenic AV malformation is quite frightening, but in fact, it's really a distraction. This patient actually had a previous trabeculectomy here somewhere, so someone was very brave, because you've got hypotony from a trabeculectomy here, you could really run into big problems. And you worry about bleeding from the AV malformation, but in fact, these bleed very slowly, and it's not at all an issue. The issue really is getting hypotony. So it's technically possible to implant tubes in these situations with various impediments where filtration won't otherwise work. But the question is, of course, and early on, when I was doing these very, very occasionally and carefully, my concern was, well, if you do these, will the tube work? Or are we just wasting our time here? Because when we did trabs in many of these cases, the trab failed, you do another trab, a trab revision, you're just endlessly doing a bleb repair work. But the tubes actually seem to work. And the reference paper really for this was from in ophthalmology in 1999 from Dale Hoyer's group at USC. And they did this randomized trial of 350 versus 500 barbell. The 500 millimeter squared barbell never made it to market. But this RCT showed that the 350 arm at 5 years, the pressures were quite, sorry, I can't actually see because of the videos are in the way. Okay, the pressures at 5 years were 13.7 on one medication, and really nobody had managed to achieve that with tubes before. With RCTs of tubes in general, pressures were in the low 20s on a couple of medications, and hence the long-standing belief that tubes didn't get low target pressures. But Dale Hoyer's group showed that it was possible to get low pressures if you used the barbell. But again, these were very difficult, more exotic situations, such as those that I've just shown. What about less exotic situations? Well, first, before I go into that, I'm just going to go through the two tubes that are available at the moment, or the two main ones, which are, of course, the Amid and the Barveld. As I mentioned, the problem with the Maltino was that it was not great pressure control in the long term. The other problem was early hypotony, and you had to ligate it to tie it off. Well, the Amid valve tackled the hypotony flow control problem. The Barveld tackled the encapsulation problem, but nobody, unfortunately, tackled both. The Amid valve's clearly got a flow restrictor. It's a medium surface area, and you've got to prime the valve and handle it carefully. The Barveld has no flow restrictor, big, very, very biocompatible surface area. And if you're not careful, the Barveld, and you get the Barveld wrong, the pressure will be zero and the eye will collapse quite dramatically. Whereas with the Amid, you're not quite such risk. And they both appeared in roughly the early 90s. So we're talking about more than 25-year-old technology now. In the barbell, of course, the key feature was this beautiful aerodynamic plate. When I first showed pictures of the barbell at Moorfields in 1999, people were shocked at the size of the actual plate. But in fact, this works very well, as we all know, and isn't that difficult to put in. In talking about aerodynamics, you can see here these micrometer micrometer gauge measurements. The amide valve is nearly 2.5 millimeters thick over a significant proportion of the plate, whereas the barbell is almost 2 millimeters thick just on the ridge, but everywhere else is about 0.9 millimeters. So the majority of the barbell is a lot thinner than the amide valve. It's also polished and less of a fiberglass magnet. But overall, with the barbell, like the Multina before it, flow control can be hard to achieve. And this is exacerbated by the large plate of the barbell, which is much bigger than the Multino. And traditionally, we use total occlusion and absorbable ligature. And after 5 weeks, this rotted and the pressure went down. The problem with the ligature technique is when the pressure goes down, you can get some fairly dramatic hypotony. And this typically would occur at 10 p.m. on a Sunday evening, and the patient would show up in the emergency department with choroidal effusions and reduced vision. So we took to using the internal occluding suture, the SuperMid, which was described by Mark Sherwood in the early 90s, but never really took off until I think Penn Cole started using it more Moorfields. And in isolation, it was Ian Murdoch who suggested about 2001 that you could use it without anything else and get away with no external ligature. And that worked for a while, but the problem with most of this was variability. So we fiddled around with putting the SuperMid all the way into the eye, or just partially into the eye and using external tenno nylons. The advantage of the external tenno nylons is you could laser them early, as long as they weren't the single restricting factor in terms of flow. So if you've got most of the flow reduced by the SuperMid and add 1 or 2 ligatures, producing a very small stepwise reduction in pressure or reduction in flow, you could later laser them fairly early and get a reduction in pressure. This is the SuperMid. And the trouble with the SuperMid is I found after a number of years that we go through batches where it was really just too tight. In other words, we were getting pressures of 40 or 50 afterwards. It was like a cork rather than a wick. So I changed to using Ethalon, which is again 3O nylon, just like the SuperMid. But the difference between the SuperMid and the Ethalon is it is a little thinner, and it seemed to produce much, much more flow. The Ethalon is a little bit more tricksy, for want of a better word, than the SuperMid. It's variable. So you've got to be a little careful, and you do need ligatures, whereas the SuperMid, often there was no flow at all. But you can actually, with a bit of manipulation, see what's coming out the back and try and gauge it, and that way avoid the very high pressures afterwards that you would get with the total occlusion technique. So what's the difference between that, the traditional technique, and this more complex DIY procedure? Is that the tenno nylon over the SuperMid gives you some flexibility that you really don't have with a single ligature, and you can adjust it to some degree. The problem we have with this technique is that the sutures swell a little bit over time. So what seems to be a little bit too much on the table can be not enough later. But on the other hand, sometimes it is too much later. So there is still unpredictability, but less so than before. The hardware situation afterwards is you've got the black tenno nylon ligatures that you can laser. You've got the blue proline holding the tube in place, the SuperMid coming out from the top of the tube, and the SuperMid, which is stitched down far enough from the limbus, hopefully not to erode, but that can be pulled later. And it's quite easy in most cases to laser the ligatures using the laser suture lysis lens. This is a Blumenthal lens shown here. But, you know, it's clearly much more difficult to get the flow right than with the enameled valve. So you might say, well, you know, why bother? This is a lot of hard work. And the reason we say why bother, it really comes from the trials. The first thing is that the tube versus trabeculectomy study used the barbell implant. And that was 1,212 patients randomized to trab with mitomycin versus a barbell 350. And this was largely portrayed to be, I'm sorry, the text on this is probably a little small on some people's screens, especially if you're looking with a phone, unless you're very myopic indeed. But anyway, you can look at the papers. This was largely portrayed to be a low risk study, and it wasn't. It must be pointed out that the majority of patients in this had either failed trabeculectomy or scleral tunnel cataract surgery. There's only 12% of them actually had clear corneal phaco. But the entry criteria were POAG or PACG with either previous pseudophakia or previous trabeculectomy. And the previous pseudophakic patients were largely scleral tunnel. And at 5 years, there actually wasn't very much difference between the groups. It's true that the tube group did better, but it wasn't a great deal better. They ended up with less glaucoma surgery afterwards, fewer failures. But whereas the trab group had slightly more patients getting off medication. But if you want to get your patient off medication, you'd only 29% chance in the trab group versus 25% chance in the tube group. So the TVT study showed that if you had a failed trab or previous scleral tunnel cataract surgery, that whether you did a second trab or a barbell, there wasn't an awful lot of difference in outcome. Armed with this information, we embarked on the primary TVT study. And I've realized I've only got the first year results on these slides, but the 3-year results are published in ophthalmology and very, very similar. And again, this was a similar bunch of investigators. The only difference between the primary TVT and the TVT is that there were 3 investigating sites in the UK with primary TVT, whereas with TVT it was just me. And the 3 investigating sites in the UK recruited 40% of the primary TVT study. So it was almost half was UK and just over half US. And again, 242 randomized, 117 analyzed in one group and 108 in the other. And the results were pretty clear cut and quite different from TVT in that the tubes didn't do so well, and trabs did better. Trabs did as well as would be expected. Tubes did worse. And the 3-year results are fairly similar as well. And the upshot seems to be that if you have a high starting pressure, tubes do better than if you have a low starting pressure. And the primary TVT study, the starting pressures tend to be lower than most of the tube studies. If you compare the tubes, there were 2 concurrent studies in the late noughties between 2006 and 2009. Jim Cyanike's Ahmed's group did the AVB study, and Don Buden's and I did the ABC study. And they both showed roughly the same thing. Barbell gave better IP control. Ahmed has slightly better safety profile. But the 5-year pooled results of the 2 studies that Don Buden's wrote up produces quite a powerful group of 514 patients at 5 years, 176 Ahmed's, 170 Barvells. And at 5 years, the difference was fairly consistent, that Barvells were doing 3 millimeters mercury better on fewer medications, which is quite a sizable difference. And that's the difference there. Over 3 millimeters mercury better for the Barbell versus the Ahmed on slightly fewer medication. And why is that? Well, we've talked about the plate difference and the plate size, but the Ahmed's also not a highly polished plate compared with the Barbell. My colleague Hagen Tima and Norbert Pfeiffer in Mainz looked at the surfaces of the Amid, Molteno, and Barvelt. In fact, the Molteno was the most highly polished plate. It was very smooth. The Barvelt was similar, but the Amid's quite rough, and in tissue culture, it really attracts fibroblasts. They stick to the plate, whereas they don't stick to the Amid or Barvelt. And while I've talked mainly about failure, there are risks of hypotony. One of the criticisms of the ABC study, we included a lot of neovasculars, which was a mistake, as they do badly anyway, and especially they go hypotenuse, as do certain types of uveitis. And in those, you really got to go for the smaller plate, or perhaps an Amid valve, or even a single plate Molteno, which I use in some of the very severe childhood uveitis. So the single plate Molteno still has a use. It's a smaller plate. It's polypropylene. It's not that biocompatible, but in eyes that have very severe uveitis from early childhood and very, very little aqueous production, that this actually works very well. The challenges in technique really are simply to get the plate in the right place and get the tube in the right place. And it really boils down to that. I see plates that are put too close to the limbus and not well positioned. And ideally, they should really be in the plate should really be in the orbit, not subconjunctivally. And you really don't want to compromise in placement because of obstacles. You want to get as far back as possible where the fibroblasts are less active and you're less likely to run into problems. I aim for roughly 10 millimeters back, and that's kind of correct. But this is what I see from time to time. This is just not good. It looks horrible, and it doesn't work well, and the erosion rate's much, much higher. And there's no logistic excuse. You really need to work on the technique. It's really just all about access. Patients with silicone oil, people ask me what to do. Well, I don't implant tubes when there's silicone oil, but I do implant tubes when there's a small amount of residual oil. And this was a patient from many years ago with who had a leaky vitrectomy port and oil in the subconjunctival space. And this really is a mess, and you want to avoid this. In this sort of patient, ideally, you want to keep the supermid in place or use an Amid valve because you don't want the oil getting into the subconjunctival space. This is the patient that I looked at. And Roger Hitchings at the time told me just go to the operating theatre and mop up the oil. And I think he was laughing because you can't mop this up. It's really just, it's all encapsulated granulomatous tissue. But you can see that even with this oil going up and down the tube did still work. And the patient miraculously achieved good pressure control. But you can see this bubble of silicone oil going up and down this Molteno tube. And this was from about 1997. It wasn't a poorly sighted eye, but we're still able to control the pressure. What about our patient with Sturge-Weber syndrome I mentioned earlier? Well, as you can see here, the post-operative result 8 days later isn't bad, and the pressure is physiological. There's no adverse effects, and you can see the tube in the AC. So the thing is, don't compromise on your placement technique because of obstacles. That one criticism I see from our trainees when they come is they take the ink and the marker and the calipers and they very, very carefully mark out a peritomy that's much too small. And then they make these enormous relaxing incisions way over the plate to compensate for the poor peritomy. The answer is throw away the marker, don't waste your time, and make a big peritomy. There's no downside to the big peritomy. You'll get the plate in the right place. And use traction sutures where need be, in the tenons, in the sclera, in the cornea, wherever. You can use, you know, sometimes I use 5 or 6, 7 silk traction sutures to get the plate in the right place. You also have to put the tube in the right place, and that means avoiding the cornea. Obviously, you don't want it blocked with iris, but you don't want it in the cornea either. This is a plate, as I mentioned before. This is the same eye a few months later. That was this is the very first one I put on top of the scleral buckle. And you can see that a few months later, it's just a nice diffuse drainage bleb. This was very early on when I started using using plates over scleral buckles and thought they would never work. And this is the same patient 13 years later. And you can see still the pressure is actually in high single figures. The amazing thing is these things work. I'm sorry, that slide got out of order somehow. I must have been drunk when I was rearranging the slides. But anyway, as I was talking about the putting the tube in and avoiding the cornea, this is a uveitic. Go back again. This is a uveitic with bridging synechiae. So you can avoid those. You've got to look in goniostomy and see where there's space. And you can go to the area where there is some open angle. There are patients where there's no open angle, especially the old neovasculars with very high synechiae. This was actually a patient with posterior polymorphous dystrophy, which is unusual. But you see patients with the angles completely zipped. You cannot put the tube in the cornea just because the angle is zipped. You've got to find a way around it. The sulcus is the place to put it in these situations. This is a very brief synopsis of a presentation I did at the American Glaucoma Society this year of a 5-year study on looking at tube implantation and corneal endothelial cell loss performed by Scott Howe. And Scott looked at 77 patients, and 64 of them completed the study. There were various dropouts for various reasons, but 64 had 5-year assessment. They were all barbells. There were a few postoperative complications that were normal in a cohort of tube patients, and a few had further procedures. But the final point of this talk, of this particular talk at American Glaucoma Society, that I'm not going to go to at great length, was that if you have a tube entry site on gonioscopy that's behind Schwalbe's line in the angle, you've got a Barvelt, remember 600 microns in diameter, so it's quite big and it'd be quite hard to get it completely behind Schwalbe's line. But if you do, you still lose about 25% of your endothelium after 5 years. If you have it just up to Schwalbe's line, but less than half of the tube behind Schwalbe's line, you get about 32% loss. If you have the tube straddling Schwalbe's line, you lose 50%. Ironically, if you have the tube in the cornea, you only lose about 32% as well. But basically, if you don't have the tube behind Schwalbe's line, you lose a lot of endothelium. And even if you do have it completely behind Schwalbe's line, there still is a risk of 24 or 25% loss. And that's the graph from that group, and that's the graph from that group. So this is an important issue. And it's not just where the tube tip is, it's important. It's where the tube is in the angle entering the AC. And typically, I know this is a 25 gauge needle. Remember, the tube's bigger than this. The tube's 23 gauge, this is 25 gauge. And you can see this is right behind Schwalbe's line. You can see it's actually through scleral spurs, so that's perfect. And if it's perfectly positioned, it's right up against the iris. You can't have it in the middle of the AC and not be in the cornea. This one is more typical tube placement, but if you look at it, it's right in the cornea. It's completely in front of Schwalbe's line. So that really does risk endothelial cell loss. And remember, the tube itself is actually bigger than that. Unfortunately, in that study, we excluded sulcus fixated tubes because we only had 2 or 3 of them. So it wasn't enough to make any sense of. But sulcus fixation can be done a different number of ways. You can go behind the iris if you've got a big iridectomy, as this patient had from a previous trabeculectomy. You can come in from the side. You don't need to go through the trabeculectomy itself. You can make your own iridectomy and put the tube in behind it. And my favorite way of doing that these days is to use the 23 gauge vitrectomy forceps and scissors. And you make a little, you can cut a little tag with the scissors and then swap them over and remove the tag from the other paracentesis. And this is easier than the traditional external technique or using vitrector. The problem with doing the PI externally over the tube entry site is that you then can't see where the tube is because the wound gets in the way. The vitrector is handy, but it's not so good with phakic eyes, and it's a little bulkier and clumsier than doing it this way. and then you just swap them around and remove the tag. Or this patient here with a fixed dilated pupil from neovascularization, you can put the tube just behind the iris, just straight in the sulcus without a PI. You've got to be very careful with the sulcus fixation because it's very, very easy to end up behind the IOL. Very easy to hit the zonules and go backwards. And this is an endoscopic view of such a tube. And you really want to avoid that, and it's very frustrating. Sometimes there's no space at all in the anterior chamber, and there's no space in the sulcus just because you've got a very, very small eye. And that is the situation where pars plana implantation is best. I don't go for pars plana implantation in most patients because it's a little awkward. It requires a vitrectomy. Even if the patient's had a previous vitrectomy, it still requires another vitrectomy. This is a patient where you can see there's actually vitreous base blocking the pars plana tube. So I tend to avoid pars plana tubes except where you actually have no other space. I also avoid these tubes, the pars plana modified tubes, either the amide or the Barvelt that are modified, because these cause erosions. Even if you patch them, any piece of plastic close to the limbus, it causes a high risk of erosion. You really got to avoid that. With aphakics, there is the risk that you'll block the tube with vitreous, and here is such a case. And with aphakics, I try and keep the tube as far away from the vitreous as possible, and I try and enter without disturbing the vitreous. So here's an aphakic with there's iris here, there's the pupil here with the vitreous. So I put the tube down here, try and keep it away from the iris, try and keep it away from any iridectomies. Try not to disturb the vitreous when you're inserting the tube. Here's an ACIOL. Well, that protects you from the vitreous, so you're safe. The one advance that has happened in tube surgery in the last couple of years is the pole glaucoma implant, which I actually helped design. I don't have really very much of a financial interest in it, but I do have some, which I should mention. But I must say they haven't paid me anything, so I can talk with it fairly freely. Talk about it fairly freely. There is one mistake here. It's actually a 340 micron plate surface area, close to that of the Barvelt. The tube diameter is 460 something microns. It's smaller than an amateur Barvelt, which are 640. So it's a good 30% smaller. And the internal tube diameter is about 126 or 127 microns. So it's big enough not to have any real resistance, but small enough not to cause the same problems potentially as an amateur Barvelt. As I say in this video, some of the measurements are not quite right. It's 340x surface area, 460 externally, and 126 inside. And it occludes with a 6.0 proline in most patients. Occasionally that's too tight and we use a 7.0, and occasionally a 6.0 is not enough and we have to use a ligature, but most people a 6.0 is enough. Flush it. Insert the plate under superior and lateral rectus in the same way as I do with a Barvelt via wide peritomy. It's a slightly bulkier plate, although less of it, it's a slightly rounder profile. So more of it is between the rectus muscles than with a Barvelt, and less of it underneath the wings. I then circumferentially place 2 9.0 proline sutures about 10 millimeters from the limbus to try and prevent the tube moving either forward or laterally. Sorry about this bit. I'm sure you don't need to watch me doing stitches, but it does. You can see the diagonal technique is quite a useful way of preventing plate movement either laterally or front to back. And remember, one of the biggest risk factors for encapsulation is movement of any implant. that stimulates fibrosis. You want to minimize micromovement and ideally keep it far from the limbus. Note the smaller tube here. You see in a minute, that's actually a 30 gauge needle. Now, it's not quite as small as a 30 gauge needle, but compared with the Barvelt here, it's a lot smaller. So that's the Barvelt on the left and the PGI on the right. And, you see, and those are roughly the same magnification videos. You see it's much smaller. And that's a 25 gauge needle going into the eye. Again, very close and parallel to the limbus. I slowly feed the tube into the anterior chamber. I secure the tube with 9-0-proline. I try and put, I use box sutures, and I try and keep them so that the knot is not near the tube. You can bury them sometimes, but the plan is to have the knot away from the limbus and away from the tube so it doesn't cause erosion. And after that's secured, then I have a look at the flow. Now, one characteristic of the PGI that's quite handy is having this little well, which you can use to judge how much aqueous is flowing and give you an idea. The proline doesn't swell as much as a Supermid or Ethlon, but it does swell a little bit afterwards. So you have to be careful. I don't actually suture the proline down anymore because it's only a 6-0, so it doesn't erode. So I usually just glue it down with Tisseel, which I use to glue on the patch as well. I actually tend to use donor pericardium now because the PGI is a much lower profile than the Barvelt. I use the fascia lata for the Barvelt and I use pericardium for the PGI. The fascia lata has the advantage that it's thicker and handier for thicker tubes. And then I glue the conjunctiva closed and put in 1 or 2 anchoring sutures just to take the tension off the glue. I don't suture extensively. But you do have to take a little bit of time to suture, to glue the conjunctiva to ensure it's holding. It's possible to implant a tube successfully in various situations with various impediments where a trab would either be impossible or would unlikely to succeed. And there are other options now that might do the same. You know, people talk about GATT and ECP and so forth. But the difference is tubes have been subjected to a number of randomized trials. So we know exactly what the evidence is and we know that they work well. And thank you for your attention. And there's more videos at some of these websites. And that's it. I'd be happy to answer any questions if anyone has any.
Oh, Keith, thanks very much for your talk. It was a very comprehensive talk. You talked about pretty much every single tip you have on your surgical technique for tubes. So I'd like to go through some questions, if that's okay.
Sure.
I have the order here is that the first question comes from Panayota. So she's asking if any tips on how to insert a plate with buckles, with eyes with encircling buckles.
Yeah, the first thing is you do need a big peritomy and you do need a very posterior dissection. The second thing is it depends which buckle. If it's a low-lying buckle like a 276 or something and it's not very, very high, you can put the plate over the top of it. That one with a sponge, the circumferential sponge, that's very unusual. That was a patient from India and I've not seen one like that before. And I just made I put the plate behind it, made a hole in the tube, in the sponge and put the tube through. The problems come when, firstly, if you need to remove a buckle, because then you've got to be very careful, because not because the retina will detach again. The retinal surgeons will all tell you that if the buckle's been there 3 months, then it's doing nothing after that, so you can take it off. But the problem is you sometimes find there's no sclera underneath.
Exactly. It gets very thin underneath it.
Yeah, so be very, very careful. If you're going to take a buckle off, make sure there's a retinal surgeon nearby, and be prepared to even patch the sclera with a patch graft if you need to. Otherwise, just avoid taking the buckle off. And that's pretty much it. The only time when I've really had very serious problems with doing that, other than the choroid appearing, was a patient years ago who had silicone oil, a uveitic with a lot of silicone oil. I could not find a tissue plane at all. And then I ended up taking the buckle out and using the buckle cavity, the capsule that the buckle was in, as a place to insert the barbelt. And I then incised the back with scissors to make it bigger, because the barbelt's bigger than the buckle in surface area. But actually, that was the only time it was really impossible to get a good tissue plane to actually put the barbelt in.
Okay. Another question comes here. So Dr. Pooley is asking if there is any space for AMET implants, in your opinion.
Yeah, I don't, you know, there's the AMET valve is certainly, you know, less effective pressure-wise than the barbelt in a lot of cases. But on the other hand, if you're doing a small number of implants, then you don't want to be putting barbelts in. The technique is too much involved, and you need workflow that works around it. The AMET valve is much easier. If you're doing 10 implants a year, something like that, then maybe you better doing AMET valves. If you've got patients that are prone to hypotony, typically the bad neovasculars, the uveitics, those that have the previous CPC, the AMET valve's a better option as well, probably.
Perfect. Any place you prefer to put a second implant? Another question.
Yeah, well, I typically, and we've submitted an abstract to AAO on this. We have a club of patients, as you probably know, where one barbell just isn't enough, and you end up putting a second one in. You have to look very carefully in that situation and try and figure out if the first one's doing anything. There aren't many tubes where they don't do anything. The ones typically that I see where it doesn't seem to be doing anything are those with low starting pressures and no previous surgery. There was some high myopes where I was doing primary barbelts on who had low starting pressures, and the tube didn't seem to be doing anything at all. But most tubes, most typically, you've got a starting pressure of 40, and the barbell got it down to 24. Well, then if you do another one, you know, that barbell's got it from 40 to 24. It's doing something. And if you put a second one in, you'll get it from 24 to 12 or something. And I have to say that anecdotally, I've had a lot of success with second tubes, getting them down. The other ones where I've got tricky are West Africans, as we all know, that scar heavily. And young West Africans, I've got some, you know, uveitic young West Africans with 2 barbelts in each eye, and their pressures are still 20 on maximum medication, but at least it's 20 and not 40. The trouble is when you do the second barbelt is you've got to go 180 degrees away, because otherwise you bang against the first one with the second one. The plate, so you put one supratemporally and the other one infranasally, otherwise they bump against each other. Yeah.
Are you using mitomycin C mainly in I mean, most of your cases?
I'm pretty much using mitomycin C always, but if it's a second barbelt, definitely get mitomycin C. And with the African patients, if it's a second barbelt, I've gone recently to using Peng's technique, which is the 1 milligram per mil of mitomycin C.
Oh, that's a lot of concentration.
One criticism I have when people come to my firm and start using mitomycin C in tubes is, you know, there's no evidence that mitomycin C works with tubes. So if you're going to use it, there's no point using a half-dry sponge. There's no point a tiny little bit of, you know, a boutique amount of mitomycin into a large sponge. if you're going to use mitomycin with a tube, you really need to slosh it in there. At the best of times, it does very little, but if you're going to use boutique amounts, you might as well stay with boutique surgery and don't do tubes. You really need to be soaking, and you know, typically to soak 2 spears with mitomycin, you need 0.7 or 0.8 mils. You're putting in 0.2 mils, you're not doing anything.
So what's your standard concentration then?
Well, my standard, well, 0.4, 0.5, whatever we've got in the pot of the way, for 5 minutes on 2 spears.
Perfect. So what's your, another question, how do you deal with hypotony after removing the stent, after injections on conservative measures fail?
Put it back in again. The nice thing, okay, I don't like going back to primary ligatures because they're too unpredictable, and I'm sorry, I think I need some juice here in my laptop or we're going to die. Okay, we're back in action. The nice thing about putting a supramid or a 3-O-ethlon in from the anterior chamber, you cut off about 10 millimeters mercury. Sorry, you cut off 10 millimeters of supramid or 3-O-ethlon, and you feed it up from the anterior chamber. You can bring the pressure from 3 or 4 up to 10 or something. It's very rare that you overshoot. Very rare that you end up with a pressure of 30 from doing that. Whereas if you go to a ligature, you can end up with a pressure of 20 or 30. So my favorite technique is just to put it back in again.
It's from the AC?
From the AC.
Yeah.
And then you don't touch the bleb or the tube externally. Then if that doesn't work, then I go and ligate.
Okay. What's your opinion of the retrobulbar diversion of aqueous humor? That's a question from Mauricio.
Well, I think that's what I do. I think that's why I put the plates so far back.
Yeah, exactly. They work well. Can you read that? This is a very long question. What proportion of tubes are you implanting in the sulcus in phakic and pseudophakic patients? Do you recommend a large irectomy to put a tube in the sulcus in a phakic patient?
Not an aphakic patient, you don't want to put the tube in the sulcus, it'll fill with vitreous. In a pseudophakic patient, you want to put the tube in the sulcus. That's easy. And increasingly, we're now looking at doing, Scott Howe is now repeating the same study, hopefully, looking at sulcus fixation, which we didn't have in our original study. And the plan is to look at sulcus and PGIs, smaller tubes, and just see what the difference is in the endothelium. But the question really when you're going pseudophakic is to, the question is when you're putting them in pseudophakics and putting it just in the sulcus with no PI, do you bevel backwards? And the answer is yes. If you're putting it with no PI, you should bevel backwards. I tend to put them through PIs and then sometimes feed them the AC through PI. But I don't use a large PI.
Perfect. What's your opinion on long scleral tunnel as described by Felix Hill from Mexico instead of a patch graft?
It's a good idea. Yeah, I've never used it. It's a good idea. My only hesitation is that I've noticed some people, when they do long scleral tunnels, tend to make the entry side a little bit too wide to compensate, because with a very long scleral tunnel, you have to be good as fiddly.
Yeah,
and you can
exactly.
make it difficult to get the tube in the AC. Then what people then do is widen the entry side and get hypotony. So you just got to be a little careful. That's my only. But I've never done it because patch graft's easier.
Okay. Have you used Shengling's patchless tube implantation technique?
I can't remember what it is.
Oh, okay. That's fine. Do you have time for more questions, Keith?
Yeah, sure.
Okay. Do you change your patch graft material when repairing an exposure? For instance, using
it depends. It depends. Yeah, it depends what's it. Usually, sometimes you get an exposure right through the middle of the patch graft, and there's still two pillars on each side. And then I use that as a bridge and stick another patch graft on top of it. Sometimes the exposure, the patch graft may have slipped slightly and the exposure's in front of it, and then you have to put another little piece on. It's important when you're fixing exposures to try and figure out why it exposed. Was it just a thin patch graft? Is it the tube moving? Is it the tube too anterior? And do you need to move it more? Do you need to put the tube in the sulcus to make the external course shorter? So there are various considerations.
Perfect. Would you advocate repositioning the tube if the endothelial cell count exceeds the central threshold?
Yeah, I do. If the endothelial cell count is starting, patients getting good data, or the endothelium looks like it's suffering, I move the tube, typically put it in the sulcus.
Perfect. Another question comes from Chile. If the vitreous gets into the tube, do you flush it or just take it out manually? What would you recommend?
Vitrectomy, you go in with the vitrector and take it out. The only trouble with that is you've got to figure out if it's going to happen again. Some questions, do you need a pars plana vitrectomy to absolutely clear, or do you just need to go and clear it? Because even with pars plana vitrectomies, you can still get bits of vitreous in the tube. It's very frustrating, but it happens. Yeah,
it does, actually. So here's another question. How short is your target in terms of tube length in the AC? If you try to leave it too short, have you experienced any retraction?
Yeah,
from the
yes
AC?
and yes. I tend to typically I was trained to make the tubes long, and I didn't like it because, when people rub the eye, the tube, when the patient rubs the eye, the tube can pendulum all over the place. And I've got videos of that, but the talk would go on forever if I showed all the videos. So I typically started doing short tubes, and the SuperMed technique was good for short tubes because typically people used to leave the tube long with the ligature technique, because when the ligature went and the pressure collapsed, the iris would go up the tube. So you leave the tube long so that doesn't happen. With the SuperMed technique, you don't need to do that because you remove the SuperMed under more controlled circumstances. So I leave the tube shorter. Unfortunately, when I left the tube shorter, then some did retract. But I still think it's nicer to have a slightly shorter tube. Since starting to use the pole glaucoma implant, the PGI, with the thinner tube, I do tend to leave them longer. And there is the risk with the smaller tube that although it's better for the cornea and better for erosion, it might be more likely to block.
Perfect. Any pearls on pre-op and post-op with tube surgery in pemphigoid?
I never operated on pemphigoid unless John Dart sent me the patient and said, this patient's got pemphigoid and he needs a tube, do it. He was the guy who looked after the pemphigoids. They'd been on whatever immunosuppression. He said it's fine to operate, then I would do it. But I would make sure they saw the corneal, whoever your corneal specialist is, who's an expert on things like pemphigoid, they need to see the patient first and okay it.
Perfect. This is a question that it seems sort of interesting for us in the third world countries. If you try the ARI implant, the Orolab implant, which is much lower cost than verbal.
We could have I haven't personally done any. We did, my group did a lot, with Don Budens. I think Alex Spratt did a lot in Ghana, and a few other people did. And I believe the results are similar to Barvelt. And when I looked at the ARI, the actual consistency of the plate's a little bit floppier than a Barvelt, but it's basically a Barvelt knockoff. So we wouldn't expect the results to be very much different.
Yeah, so they seem to be pretty similar. Would you worry about a tube rubbing against and pushing the iris?
No. A lot of people have stood up over the years and said, oh, the tube mustn't touch the iris, it causes uveitis, it causes this, it causes that. and it doesn't cause uveitis. We actually, in Scott Howe's study, we actually looked at flare and as a risk factor for endothelial cell loss, and flare made no difference to endothelial cell loss. Half the patients in that study were uveitic, and they had higher flare, but the tube position didn't seem to make any difference to the flare. Tube against the cornea doesn't increase flare significantly. Tube against the iris. Tube against the iris does cause a little bit of depigmentation in time, and if you've got patients with ICE and you put the tube against the iris, you just find the iris contracting close and peaking close to the tube. So it's not ideal. You can end up with pupil simply by rubbing it if it's an ICE syndrome. But all of that is still better than the tube rubbing the cornea.
Yeah, that's definitely good. Would you consider a tube as a primary surgery for high myopes? With no
as I mentioned,
glaucoma surgery?
For a while, I didn't like trabs because trab and a high myopes are a white knuckle ride. But I just my experience and the primary TVT studies seem to suggest that primary tubes in primary open-angle glaucoma just don't seem to work as well. So and typically the high myopes having primary tubes, if their starting pressures of 13 or 14, on medication, you ended up with pressures of 13 or 14 on medication. You just never really got them down any further. If they start off with pressure of 35 on medication, then a tube is worthwhile. They do seem to work.
Yeah. What external landmark do you use to ensure that the tube is 50% or more behind the Schwalbe's line?
I aim to be as close to iris as possible. So the landmark I use is the iris. I'm trying to scrape the iris.
Perfect.
And that's pretty much it. I just go as close to the iris as I possibly can.
Perfect. Do you still have more time, Keith? There are a lot of questions coming in. So.
Yeah, what time is it? Yeah.
Probably 5 more minutes and then.
That's fine. I don't make myself 5 minutes.
I know. Sorry. So here, well, we've gone through mitomycin C. Here's a question about needlings for AMIDs, but you said you don't do many AMIDs, so any experience on that?
Yeah, but, I mean, I've done some AMIDs, but I've involved in a lot of discussions over tubes, and I think most of the AMID users will tell you that the needlings are not that effective. It scars up again. The experience in general, and I think I speak for most people, is that if you even excising the capsule and using a lot of mitomycin with AMIDs, even with barbells, doesn't work that well.
Perfect. What's your opinion in case of glaucoma and PKP for tube insertion? Anterior chamber, so you put it in the anterior chamber, the sulcus, or pars plana?
Depends what space there is. I tend to put them in the anterior chamber behind the host, not behind the donor. If the chamber's deep, if it looks like it's going to get anywhere near the cornea, then I put it in the sulcus.
Perfect. So here it says that there are some studies showing that AMIDs are working well with mitomycin C. Small samples, but they're very similar, the results between AMIDs and variables. So if this was demonstrated by further studies, do you worry about getting pre-mitomycin C injections to make AMID works as well as variables, adding the benefit of safety?
Well, as I said before, there's no hard evidence that mitomycin works with any of them. And Barvel, without mitomycin C, we don't feel gives us reliable enough pressure control. We find it better with mito. Okay, AMID valve with mito might improve the outcome of AMID, but overall,
yes.
The AMID fundamentally has got some design flaws. You know, the plate is not very biocompatible.
Okay. So I think we should leave it here. I'm sorry about not answering every question, but they're still coming. So I thank you for your time.
You actually did pretty well, Francisco.
Do you have time for one or two more questions then? Do you have time for one or two more questions?
I can probably do two more, maybe. I got about 5 minutes and I really gotta go.
Yeah, I know. So here Andrew asks, what do you do in sleep-up angles and phakic eyes? Would you consider sulcus IOL?
For what? Sorry? Sleep-up angles and phakic eyes? Yeah, I actually do put sulcus tubes in phakic eyes. Obviously, it's a little trickier. There's two ways to approach it. You can put it in the sulcus, you can have the entry in the sulcus and then the tube go through the iris into the AC, or you could just leave it in the sulcus. And I must say, I leave it in the sulcus. To be honest, even if it touches the lens, it doesn't really matter. You know, you can get very, very localized lens opacity, but I've never seen bad cataract, at least not. You might say, well, these patients might get cataract younger than usual, but they're getting a tube, they've got glaucoma, they're on glaucoma medication, they're going to get a cataract anyway at some point. But they don't suddenly get a cataract 6 months later from the tube touching the lens, surprisingly.
Yeah, perfect. Okay, so that's it. I thank you very much, Keith, for agreeing on doing this webinar. I think it's been very, very helpful for all of us. And I really appreciate your time, very nice talk, your videos. So it's a big, big hug from all the Chilean community. And also I want to thank everyone who joined us today. I'm sorry I couldn't read all the questions, but I think we've been through pretty much every single aspect on tube surgery. So thanks everyone who joined us today.
Thanks so much, Francisco. Hope all's well in Chile. Take care.
Take care, you too.
Thanks, Francisco, for organizing. Great talk. Thanks for that. Do that again. We're more likely to listen to Keith talks if you organize it than if we organize it. So
I know. Well, Keith just said there is more people here that there ever was a teaching. So
I know exactly.
We should organize it. Yeah.
Yeah. No, I'm just joking. But thanks for great effort. Thank you very much. Take care.
Thank you. Thanks to everyone that joined us today.
Thank you, Francis.